wasn't, the data that we did have available to us was whether they were living in an urban or a rural setting, and that was not significant in these analyses. We did also look at the entire set of people 45 to 85, no matter what their chronic conditions. We did find for the whole group, people participated less if they lived in a rural setting, but it didn't come out for people with stroke. And the general health perceptions, if people had poor general health perceptions, they were less likely to walk outdoors and less likely to participate. Again, in a larger group, it didn't come out in the stroke groups. So there were differences between stroke and non-stroke.
Thank you, Prof.
I would like to ask that, can you remind me your instrument to measure social participation?
It was, there's a variety of questions in the questionnaire, and so people are asked if they participate, for example, in church, if they participate in some sort of recreation activity or visit family, and there's a whole long list of things. And they're asked if they do it daily, weekly, monthly, yearly, or never. And it's a combination of all of those answers together, and the more common category is the one that's chosen. So it's a combined category.
Yeah, because I saw that you found some differences in men and women and different age groups. So you might interested in subgroup analysis to tease out which dimension that women or men will affect the most.
Absolutely, yes. We should look at that separately.
Thank you very much. Thank you. Any other question?
All right, thanks so much. Appreciate that. Our next speaker is on the list, at least he's not available, so we're going to go to the last speaker. The good news is then we'll all get out a little bit earlier, but I'm delighted to introduce Phan, who's a PhD candidate at the Menzies Institute at the University of Tasmania.
Thank you, Dr. Reeves. So I acknowledge my co-authors and have no disclosures to declare. Women have been reported to have worse outcome after stroke compared to men. There's some evidence that women receive evidence-based care less often than men. However, the factors that may explain the sex differences in stroke management are poorly understood. Many investigators failed to report sex-specific findings or use the modeling that were not focused on the sex difference. Our aims were to quantify the magnitude of the sex differences in management of stroke using an individual participant data meta-analysis, and then to identify the factors that may contribute to these sex differences. Participants were people with incident stroke from the International Stroke Outcome Studies, as is known in STRUCT, including 13 population-based studies conducted between 1987 to 2013, and these studies were conducted in Europe, South America, the Caribbean, and Australasia. The table shows the details of included cohort, baseline with first ever stroke cases. There were 16,964 first ever stroke cases, but fewer studies have the data on management and treatment after stroke, including 6 studies with admission medication, 12 studies with hospital investigation, 3 studies with surgical intervention, and 5 studies with discharge medication. Studies assessed in this study in the meta-analysis included social demographics such as age, socioeconomic status, stroke-related factors including stroke type or stroke severity, pre-stroke health including level of independence, and other cardiovascular disease. Log binomial regression were used to estimate the prevalence ratio of receiving stroke management for women compared to men. And study-specific multivariable models adjusted for all potential confounding factors were combined using random effects meta-analysis. At the time of admission, women were older, not living with a spouse, living in institution, more dependent before stroke compared to men. They also more often had atrial fibrillation, hypertension, dementia, and have more severe stroke compared to men. Men were often smokers or drinkers and more often had coexisting ischemic heart disease or peripheral vascular disease compared to women. The table shows the direction of sex differences in stroke management and in treatment. There was few differences between men and women in stroke treatment. However, we have found that women were less likely to receive carotid investigation, which is statistically significant in 4 out of 9 studies, and they're less likely to receive echocardiography, which is significantly in 3 out of 7 studies compared to men. Those forest plots illustrate the poor estimates of the sex differences in received admission antihypertensive. As can be seen from the graph, the diamond illustrate the poor estimate, and the I-square and the heterogeneity between studies were examined by I-square statistics. And women were about 8% more likely to receive antihypertensive compared to men, and the difference were formally explained by women's greater age and more presence of hypertension. In terms of the differences between men in admission antiplatelets, there's a tendency that women receive less antiplatelets at admission compared to men, and the difference was greater after adjusting for women's greater age and atrial fibrillation. We have found no sex differences in admission anticoagulants in both unadjusted and adjusted analysis. Women and men receive equal neuroimaging at acute stroke among 12 studies. We found that women received less carotid investigation at admission, with the poor estimate being 0.89, and the difference was explained by women's greater age, more severe stroke, and the presence of AF. Women also received less echocardiography, with the poor estimate being 0.83, and the difference was mainly explained by women greater age and more severe stroke. The presence of AF or ischemic heart disease also contribute to the sex difference, but in fewer studies. We have found that there were no sex differences in receiving antihypertensive at discharge in both unadjusted and adjusted analysis. Similarly, no significant difference in the differences between men and women in receiving antiplatelets at discharge. We have found that women and men receive equal anticoagulants at discharge. This study has a novel analysis focuses on the sex differences using the individual meta-analysis of the large data sets. However, this study is limited by the fact that some studies were conducted a long time ago and focus on high-income country. And we have limited data on current evidence-based therapies. We don't have the data on stroke unit access, care plan at discharge, or rehabilitation. In conclusion, women have fewer in-hospital investigation than men, including echocardiography and carotid investigations. However, the differences were associated with age and stroke severity. These findings highlight the importance of improving care for the elderly and management of risk factors well to reduce the stroke severity. Thank you for your attention.
Any questions for Dr. Phan?
Thank you for your presentation. Did you find any difference regarding old studies and new ones is there any difference or any times also like differences increasing or decreasing?
Yeah, actually, unfortunately, we have fewer studies, like just 3 studies with the data on antiplatelets or anticoagulants. So we didn't find any sex difference in the study conducted a long time ago, and the new study. But because we have few study, so we could not find the difference between those studies.
And now, based on your results, would you recommend that a stroke campaign be adapted according to sex? Or?
Yeah, so actually, based on my current research with my co-authors, we have found that women were about 35% more likely to die after 1 year, have poorer functional outcome and poorer quality of life after stroke. But the difference was mainly explained by women's greater age, more severe stroke, and the presence of atrial fibrillation, rather than the differences in care between men and women. Yeah, so although we found that women receive less in hospital investigation, but it did not contribute to the sex difference in outcome.
Thank you.
Thank you.
Any other questions? So I'm assuming you didn't have detailed data about the indication for carotid investigation or echocardiography, like the studies didn't give you any more detailed data about why or why not a investigation was made, other than perhaps having the history of AFib. Do you have any other information that give you some clues as to why some women were not investigated for carotid?
Yeah, so actually, I assume that because women may have more embolic strokes compared to men, so that's the reason why men was more likely to receive carotid investigation rather than men. So I think it's depends on the mechanism of a stroke type. Yeah. Any other question?
All right, thank you very much.
Thank you very much.
Okay, so that was our last presentation, so appreciate you attending today and enjoy the evening.